and I enjoy giving this lecture. It'll give you the tools to pass your boards. It'll also give you the tools to be a better pediatrician, because there's a lot of, I'll give you all my secrets on how I take care of my patients. So use it for your boards, but also use it to take care of your patients. So we have a lot to cover, and usually I do it 2 hours, and I go through the first list, and then the next hour and 45 minutes is the second list. So the way it's set up is that there's going to be a question to start off and some audience participation, and then we'll talk about the topic. So first question for diabetes. A parent calls your office concerned that their child may have diabetes. Their child is a 2-year-old female with a history of increased thirst but no increased urine output. Her weight is stable and her appetite is normal. Her grandmother has type 2, and they checked the child's blood sugar on the grandmother's meter, and it read 150. The most appropriate next step in managing is A, admit to the hospital for diabetes education, B, give 2 units of Novolog, C, reassurance and education concerning the diagnosis and presentation of diabetes, D, have her drink water and check her blood sugar in 2 hours, or E, have her come to the clinic for a glucose tolerance test. You can go ahead and put your answers in. Very good. C, that's the correct answer. It's reassurance and education concerning the diagnosis. This is a very common situation. Everyone has glucose meters at home. Everyone's grandmother seems to have diabetes, and so they're always checking, and we get these panic calls, or the pediatricians do, and then sometimes they'll talk to us. But it's important you understand what the definition and criteria of diabetes is. It is the random glucose greater than 200 with symptoms, polyuria, polydipsia, or polyphagia. And that's usually going to be your type 1s. Second one is a fasting glucose greater than 126, and that means no intake for 8 hours, or a 2-hour glucose with a random glucose during that test of greater than 200. More recent one is this A1C. That's been added over the past few years, and it's a A1C greater than 6.5%. And I do want to point out this one reference here, the diabetes care. Every January, if you're going to read anything about diabetes, read about diabetes care, their January edition, because it has all the recommendations, anything that's new about diabetes, whether that be adult or kids, gestational, but it'll give you the newest stuff and the recommendations for taking care of kids with diabetes. Other definitions that are important: normal glucose less than 100, impaired fasting glucose, okay, 100 to 125. You're beginning to go down that slippery slope toward diabetes. And an impaired glucose tolerance between 140 and 200. So these are the ones that, again, you're on your way to diabetes if you don't do something about it. If you have the impaired fasting glucose, the impaired glucose tolerance, or if your A1C is in the range of 5.7 to 6.4%. Those kids are at risk for diabetes, and you got to intervene, otherwise they're going to get diabetes. Now, what are you going to do when you're trying to figure this out? Are you going to do a fasting versus a glucose tolerance test? The American Diabetes Association still says that you should get the fasting because it's more convenient. Nobody likes to take that glucose stuff. I don't know if anyone's ever tried it. Some ladies that are pregnant sometimes. Most kids will get sick on it because it's so sweet. It's less expensive and obviously less invasive. But there is a place for the glucose tolerance test. Those are the kids that are on that slippery slope down to getting diabetes. So if they have the impaired fasting glucose between 100 and 125, or if they just look like they're going to get diabetes, you know, they have a family history. You know, you see those kids, right? You're like, oh, that poor kid. Family history of type 2, high BMI. If they have the acanthosis nigricans, the dark skin underneath the neck, the arms, we'll talk about that in a minute. Non-Caucasian, if they have polycystic ovarian. Those are the kids you have to stress their pancreas to see how they're going to do. So acanthosis, this is the thing that comes in and the mom's like, a kid's neck is really dirty and I can't seem to clean it. That's often the complaint that they have. And they're scrubbing and scrubbing on the neck and it doesn't go away because it's not dirt. It's the acanthosis. A lot of times people don't even notice it, and you're doing an exam and you have to point that out. You notice right here in the neck, again, under the arms, on the knuckles, sometimes underneath the breast for ladies. You say, this is oh, I've noticed that. I don't know what it is. Well, that's what it is. It's a risk factor for getting type 2 diabetes. Now, it's an increase in the, there's a hyperplasia of the dermis and the epidermis. It's not more melanocytes. But again, when you see that, you got to rule out insulin resistance, so you got to get a fasting glucose and insulin, and then rule out lipid abnormalities, the low HDL and the elevated triglycerides. So who you get, I mean, years ago when I graduated my fellowship in 93, and really type 2 hadn't really started then. And then between like 93 and 98, it started to get pretty crazy, and we were like, oh my goodness, you know. This is like an adult problem, but now it's our problem and trying to figure out what we needed to do and who to screen. So these screening recommendations are pretty steadfast. There have been a few that have been added, but the most important one is your BMI. You got to look at the BMI chart. If their BMI is greater than 85th percentile, that starts the ball rolling. You got to think about type 2 diabetes. Because again, type 2 you can live with for years potentially, and by the time you get diagnosed, you may have damage. Okay, so you got to screen them and get on them earlier. So high BMI and two other risk factors. Family history in a first or second degree relative. Race or ethnicity, again, the non-Caucasians are going to get a more risk for the type 2 diabetes. If they have signs of insulin resistance, the acanthosis nigricans, hypertension, dyslipidemia, polycystic, and then the small for gestational age. I mean, those people are at huge risk for getting type 2, and you always think, well, type 2, you think about big, not small. And what happens with small for gestational age, when they come out, everything's kind of small, including their pancreas, including their reserve of islet cells. And so a lot of times their islet cells will burn out and they will or not work as well, and that puts them at risk for type 2. This also is a relatively new one. This mom, if she has diabetes or gestational diabetes during that kid's birth, that kid is at more risk for type 2 diabetes. You begin at the age of 10 or the onset of puberty, and why is that? Because puberty is a time of insulin resistance. You have those huge growth hormone surges during puberty. And if you're kind of teetering on the edge, you know, you're heavy, you have a family history, that puberty might push you over the edge because all of a sudden you're insulin resistant. And if everything's good, it's a fasting glucose every 3 years. And again, the Diabetes Care Journal will give you all that information. Type 1 versus type 2, a lot of times, okay, they come in and they're sick and they're, you know, they need help. They have diabetes, and the biggest question is type 1 versus type 2, and it seems like they'd rather have type 2 because it's like less severe or something, because they don't have to take the shots, you know, and I can understand that, but neither of them is more severe than the other. The bottom line, you have to take care of the two of them. But a lot of people want to know, which one do I have? And there's no one test that's going to tell you. Now, the board test is to get the antibodies. Okay, because that's a board question. Get the antibodies, and that's all you have to do, and you got the answer. Clinically, it's not that easy. Really, time's going to be able to tell. You look at a kid who's at all the risk factors for type 2, and you stabilize them, and then you say, okay, you know, we may be able to do the oral medicine, but you're going to have to diet and exercise, change your diet, change your eating habits, change your exercise pattern. And then they could turn it around, potentially. Or they may not. You just have to watch them carefully. But again, the board answer is just to get the antibodies. Now, this HLA, that's another great board question. They love asking this. The DR3, DR4, or DQ is a strong association with type 1 diabetes, not type 2. Type 2, again, most of them are asymptomatic. That's why you guys got to be out there and beating the bushes and looking at that BMI curve and then screening them for diabetes. About a third are going to present with ketones. Up to 10% can actually present in DKA, okay? But again, majority of non-Caucasian, they're in puberty. There's a strong family history of type 2, rare for type 1, and they always beat their brains. You know, they're sitting there, nobody has type 1 in my family or my husband's family, and that's usually the case with type 1s, but type 2s is a strong family history. Because if you have, you know, something in the genetics, if you have identical twins with identical genes, if one of them gets type 2, you know, nearly 100% chance the other one's going to get type 2. But with type 1, it's only about 30 to 50%. Because, again, remember with type 1, it's a genetic predisposition, and then some stress kicks you into getting type 1. Again, high BMI and acanthosis. So what are you supposed to do? So you make the diagnosis of type 2, and they're pretty stable. They're not in the hospital. Well, there's weight maintenance versus weight reduction. You know, in weight maintenance, if you use with children with continued linear growth, but I always say, that kid needs to grow to 7 feet to grow into his weight. They need to lose weight, you know? And that's always taboo in peds. Oh, they can't lose it. They need to lose weight, okay? That's always a, touchy situation and talk you have to have with the parents. But, there is some growth, but again, there's only so much growth you can do for some of these kids. But again, you got to get them to lose weight, and not drastic, just like with a healthy, a few pounds a month, but they just need to lose weight. But only about 10% of the time you're going to be able to manage kids with diabetes with weight and exercise and weight reduction. And the exercise is like 60 minutes a day. They got to be sweaty. They got to get their heart rate. They got to work themselves up to 60 minutes a day. Which, they ride their bicycle. They walk in the school up and down the stairs. I'm like, that's not exercise. It's amazing what people will think is exercise. So anyway, so 60 minutes of exercise a day is what they need to work up to. Now, the meds, the only two that are FDA approved for kids are insulin and metformin. That doesn't mean that's the only ones we use. But again, you have to have a lot of experience in it to be able to use some of the other medicines. And so again, who gets treatment? You go to the drugs, asymptomatic patients who fail to reach glycemic control after a few months, or if they're symptomatic at presentation and their A1C is above 8.5%. Those are the ones you're going to want to start drugs on. And again, the drugs, insulin and metformin, but this is a little older study. This is the Lawson-Wilkins Pediatric Endocrine Society, kind of like the AAP for pediatricians. And they surveyed 150 members, and interesting, half of them started insulin and half of them started oral. And out of the oral, there was most of them used metformin, but there were others that were used. And again, if you have a huge following of type 2s, you can say, well, in my practice of 200 patients, I've used, sulfonylureas with safety. But again, you don't want to be the first one on your block to say, I think I'll try this, And so you want to get them to a big center that takes care of type 2. And in Dayton, we don't have a lot of type 2s. We probably have 10, 15% of our patients are type 2. Cincinnati, which is a huge fellowship, also has a lot of type 2s down there. So sometimes I go down there. Again, the subtlety of the screening, we always talk about complications. You got to keep your blood sugars good to avoid complications. But again, it could be subtle with type 2s. You don't know how long they've had it. So you got to screen them at diagnosis, which is different than type 1s. At type 1s, you screen at 5 years. Okay, so that's a potential good board question. So what do you screen for? Eyes and kidneys and dyslipidemia. Okay. Now, the one other thing that's a little bit different about type 2 is they get this hyperosmolar coma, the honk. Again, I was like, oh, internal medicine, I remember that. No, the kids are getting it now, okay? And this is interesting. They come in, and they have huge, like scary high blood sugars. They're usually in 1,000, okay? But they don't have much ketones. Their bicarb is about 15. Not much ketones or osms. They are really, really high, and they usually come in a comatose state. And the theory is that, again, type 2s, they have insulin. So there's enough insulin on board to prevent the ketones from forming, but not enough insulin on board to prevent that high blood sugar, okay? So again, new onsets, about 4% of type 2s will present this way, and over 10% will die. So again, it's important that you recognize it. And the management is pretty similar to DKA, except for the fluids. You're going to do slow, just like with DKA. Everything's slow. It took a while to get there. You don't have to change it overnight. But you're going to use normal saline as opposed to half normal because their osms are so high, you don't want to give them too much free water. Okay, so you're going to want to give them normal saline with K over the first, 12 to 24 hours, and then half normal after that. Same thing, once their blood sugars start going down, you're going to have to add glucose when they're less than 250. Obviously, you have an insulin drip, and then obviously antibiotics if clinically indicated. But again, do slow, just like DKA, but the only difference with DKA is that you're using the normal saline for a while. Okay, so on to metabolic syndrome, another adult problem that now we have to take care of, right? So you see a 13-year-old male in the clinic and a BMI, increased waist circumference, the BMI greater than 95th percentile, a blood pressure greater than 95th percentile. He has high triglycerides and low HDL, and you diagnose metabolic syndrome. You need to counsel and screen for which associated diseases? A, fatty liver, B, type 2, C, cardiovascular, D, A, B, and C, and then E, hypothyroid. So you can go ahead and put your answers in. Very good. So always those people like put in the 2%. It's like, oh, that's my answer, right? Even though you know, right? So, but yeah, I mean, and you're good test takers. You always pick the ones with A, B, and C. Very good. Okay, so metabolic syndrome is an adult problem again, but now we're dealing with it. Now, the adult definition is a lot more steadfast. We're still sort of fluid and trying to figure out what it is in pediatrics, okay? But in the adults, it's obesity, increased waist circumference, and high blood pressure, high triglycerides and low HDL, and they also have impaired glucose tolerance, diabetes, or insulin resistance. In kids, they're like, okay, what is it in kids? Well, back in 2008, there was a publication that looked at 27 publications. They reviewed it, this guy Ford and Lee, and they actually found 40 different definitions for metabolic syndrome in those 27 publications. They all use blood pressure, and they all use lipids. The BMI and the glucose were in there, but they had varying amounts, and they said, well, we really need to think about this and get a better definition. So that was in 2008. Was it 2012? And still no set definition, you know, in pediatrics. Most agree you have to have the presence of 3 of the 5 problems: obesity, high blood pressure, high triglycerides, low HDL, and a glucose intolerance. So again, if you see these kids, you're going to screen them like you do. You get them the fasting lipid profile, and again, high triglycerides and low HDL. You also would want to get, you know, looking for insulin resistance, a glucose and insulin, and an A1C on those fasting blood sugars, fasting blood labs. Treatment, again, diet and exercise. Some people are using metformin and the TZDs, but again, metformin is the only one that's available in, or FDA approved in pediatrics. For some reason, the boards like to make a difference between the initial definition of metabolic syndrome and then associated problems. I don't know why that's important, but so be careful of initial definition versus associated problems. The things that they're at risk for, but not part of the definition, again, type 2, cardiovascular disease, fatty liver, and acanthosis nigricans. Okay, on to type 1. You see a 7-year-old with type 1 because his morning blood sugars are always elevated. He's on 12 NPH and a sliding scale of Novolog in the morning, a sliding scale of Novolog at dinner, and 6 units of NPH at bedtime. You recommend, because of the high blood sugars in the morning, increasing his evening NPH to 8, changing his NPH to Lantus, decreasing his NPH to 6, checking his blood sugar at 3 in the morning, and changing his sliding scale at dinner. So you recommend, go ahead, put in your answer. And very good, the correct answer is D. So you want to check it at 3 in the morning. High blood sugars in the morning are either too much insulin or not enough insulin, okay? So I always think about endocrine. It's either too much, too little, just right. You know, kind of like the 3 bears. That's our mantra there. So we got to figure out what's going on with this kid. So high blood sugars in the morning. 2 things could be happening. He could be sleeping. Blood sugar goes low in the middle of the night. They sleep through it. That always scares the bejeebers out of parents, but they can sleep through it. Their body has that protection. Then their counter-regulatory hormones kick in, and next thing you know, they wake up in the morning, their blood sugar is really high. That's a Samoji, right? They had an insulin reaction. The other thing, which is more common, because especially during adolescence, is that growth hormone. Growth hormone causes something called dawn phenomenon, because your growth hormone overnight, you get peaks of growth hormone. Growth hormone makes your insulin not work as well, and it makes your liver release glucose. So with the dawn phenomenon, your blood sugars are continually going up overnight, and then you wake up with a high blood sugar. So again, you check at 3 in the morning. If you're high at 3 and you're high at 8 in the morning, you're having the dawn phenomenon, and you need more overnight insulin, whether that be Lantus or NPH. If you're having the Samoji, your blood sugar drops down. Then you check it, it's high. With that, you need less of the overnight insulin. Okay, so it's very important. And I always say, guess what? And they're like, oh, Dr. Pfeiffer, we have to check that 3 in the morning. I was like, yeah, sorry. But there's some parents, to be honest with you, they check. I have to tell them you don't have to check all the time. Some parents, they just, God bless them, they just can't sleep. And they just check every morning at 3 in the morning. The kid could have diabetes for years and years, but they feel that comfort. They said, I just will sleep better. I'll just wake up, do it. They're good. I'll sleep better. But that 3 in the morning usually is not the best news for some parents. So type 1, again, that's still pediatrics, but again, that's kind of changing. There are 40 and 50-year-olds that are getting type 1. So really they should kind of call it autoimmune versus non-autoimmune disease, right? So this is the autoimmune one. It's 2 in 1,000, increases up to 1 in 360 16-year-olds. Peaks at 5 to 7 due to infection, and then puberty due to the hormones. In Dayton, we seem to get, most of our kids are young, less than 5, but we seem to have that peak at 5 to 7. And again, the fall and the winter are the most common times to present because of the infections. And again, we talked about you have to have this genetic predisposition. You have some kind of dormant gene, right? And something has to activate. There's some stress that activates that gene. And what are the stresses? Usually it's infections. Enterovirus, Coxsackie, rubella. That early exposure to milk, that's kind of gone back and forth. There's like one team says yes and one team says no, and they're kind of fighting all the time. But the theory is that if you get milk too soon, again, you have your fenestrated gut, you get a lot of the milk protein into your bloodstream at a younger age. There's a protein on the milk and a protein on the islet cells that look very similar. And then your body makes antibodies to the protein on the milk, and then it gets confused and it starts attacking the islet cells. So that's the theory behind that. So I just tell, if I have a kid with diabetes and I notice the mom's pregnant, I'm just like, don't give them milk before 12 months of age. And just because of that potential. They can use, breast milk obviously is fine. Even milk-based formulas, I would say stay away from those. Try the soy. There's no science behind it, but these parents will do anything they could to potentially avoid diabetes in another kid. By the time they come in, 90% of their beta cells are destroyed. Okay, so that remaining 10% is what's going to let them go through that honeymoon phase. Again, the HLA, you got to know HLA. DR3, DR4, there's a 2 to 3-fold increase. DR3 and DR4 is 7 to 10 increase. So again, DKA, as far as acute problems, 25% initial presentation for the type 1, but again, about 10% of type 2s can present that way. Definition, glucose greater than 300, pH less than 7.3, and a bicarb less than 15. And again, treatment, you guys can probably do this in your sleep, as far as you have so many. Unfortunately, we have a lot of kids in Dayton that teach the residents how to do this because they keep coming in. But the normal saline bolus, oh, that's sad, 10 to 20 cc's per kilo, and then slow. You don't have to do anything quickly. Do it slowly. Correct them. Half normal with some K. And then you add the sugar once their blood sugar, add D5, once their blood sugar starts hitting less than 250. You need insulin. They no longer need an insulin bolus. They used to do that, give them a bolus. That just sort of dissipates. It's really not important. It's the insulin drip, 0.1 units per kilo. And again, the D5 is added when the blood sugar less than 250. Because your blood sugar is going to correct a lot faster than your acidosis. But the reason they're so sick is because of the acidosis. So keep the insulin going so to correct the acidosis, and then use the glucose so they don't get hypoglycemic. Bicarb, very controversial. I think I've seen it done. I've been, again, doing this. My fellowship started in 1990, maybe 5 times. And those poor kids were on death's door. I mean, they were running out of options. So that's the time I've seen it. Just to use it, just say, oh, let's try some bicarb. I mean, that's just not done. But there's a question. I remember seeing a board question. It's never done. It's almost never done. Nothing's never, right? So it's the almost never. And the almost never, but you think about it in the kids that are really on death's door. But be careful when you give it because of the cardiac arrhythmias, okay? So you don't want to give it as a bolus. Cerebral edema, complications, a lot of good board questions on complications of diabetes, okay? Cerebral edema is the one, and that's the one that just happens in kids. 1 to 5%, and 6 to 12 hours. So it's not the immediate thing that's they're going to, there's a board question I saw one time, what's the initial complication of DKA? and they put cerebral edema first, and so people that just didn't want to read the rest of the answers, they said, oh, there's that cerebral edema. I remember that was bad. But the initial complication is shock. They're in shock, okay? But this is the 6 to 12 hours later after you've tucked them in and hopefully you're lying down, and they come to you and knock on the door and say, you know, a kid with diabetes has a terrible headache. You need to get up and see that kid, okay? Headache, so they're having increased pressure in their head, throwing up, delirious, lethargic, lower heart rate, higher blood pressure, you know, part of that Cushing's triad. And it's seen about 1%. If you see it, it's mannitol and hyperventilation. They always try to figure out who gets it. Why does not? Only kids get it. Adults don't get it. You know, adults' treatment for DKA is like 2 large bore IVs, and they just get fluid in as fast as they can. And that's one of the problems, because a lot of these kids start off in an adult ER, right? So you want to make sure that you figure out how much fluid that kid has gotten in that outside ER, and then minus that so you don't fluid overload them, okay? But who gets them? Like the 2 big risk factors are the less than 5 and the new onsets. Okay, so those are probably the 2 bigger ones. But the longer you've had it, the more likely, the more at risk you are. So very low bicarb, high BUN, like you're really dehydrated. This lesser increase of serum sodium of the, you have the corrected sodium. Okay, sorry, go back. When they come in, what do they look like? Their blood sugar is super high and their sodium is super low, right? Because they have like a pseudo-hyponatremia secondary to the fluid shifts. But that corrected sodium right there in the middle of the teeter-totter, you know, there's a formula for that. It was like 1.6 for every 100, over 100, I think it is. And that should be part of your flow sheet, because that corrected sodium should always stay the same. So as your glucose starts going down, your sodium should start going up, but your corrected sodium should always be the same. If your corrected sodium starts going down, you're fluid overloading them. If your corrected sodium starts going up, you're not giving them enough fluid, okay? So make sure you have that corrected sodium as part of your flow sheet when you're dealing with these kids with DKA. But again, people, even kids that are meticulously cared for, can get this cerebral edema. So just make sure things are documented. I mean, but if you mess up a little bit, they're going to say, oh, it's probably because, you know, you fluid overloaded them. So just, you know, make sure you're documenting, you're doing good exams. Part of your every 2 to 3 hour lab should be every 2 to 3 hour neuro checks. Because again, mortality is 20%. So obviously something you don't want to fool around with. Other complications, hypokalemia. Again, they have total body potassium is low. What happens again, when you're acidotic, the potassium goes outside of the cell. So when they come in, they're like, oh my gosh, your potassium is, you know, 6, you know, 7. They could be really high. But then as you correct the acidosis, it goes back in. So everyone's always afraid to start potassium in their fluids because their potassium initially is so high. But that's all in the serum. Their total body is depleted. And they're just going to be sucked right back into the cell, and you're not going to be able to keep up with them. You know, so they always like, oh, Dr. Pfeiffer, this kid's ready to transition. The glucose looks good. The bicarb looks good. I'm like, what's the potassium? That's what scares me. I don't want these kids on the floor because, you know, with these low potassiums and these potential arrhythmias, that's what's going to cause the problem. Oh, it's like 2.9. I'm like, nope, I don't want to, you know. And so I'm not always that popular when I try and take the kids. But, you know, it's easy in the ICU. They got continuous monitoring. You know, these kids, they stick them in the back room, you know, on the floor, and, you know, they're not monitored. So make sure you get their potassium. You know, eat their bananas or get their K-Phos or whatever they need to do, but get that potassium up, okay? EKG changes, they love asking questions on EKG changes on the board. So, again, peak T waves for hyperkalemia and the U waves for hypokalemia, excuse me. So know your EKG changes. Shock, again, the initial complication of DKA is shock. Okay? And this is also a great board question. Recurrent DKA, they're not taking their insulin. They just are not taking their insulin. And then they lie to you, and then you're like, come on, I know I'm not an idiot. I know you're not taking your insulin. Oh, no, I'm taking my insulin. Anyway, so I get some battles with some of these parents sometimes. So anyway, I don't want to go to Dr. Pfeiffer anymore. She's mean. I'm like, I'm not mean. I'm just like, you know, telling you like it is, you know. So with Lantus, though, I mean, I think it's gone down significantly. If they can just remember to take their Lantus, you know, they don't come in and decay. They might not have good blood sugars, but with the NPH, that was twice a day, and the easier you make things with kids, the better they do. So some of the things we're going to talk about now: diet, insulin, sick day rules, and follow-up. So this has progressed over time. You know, this is now the new food pyramid, okay? It's the food plate, okay? And I asked the dietitian, I'm like, you know, first they had the pyramid, and they thought that was really confusing. And then they had the pyramid with the little guy, like, running up the side, and that really, like, knocked everyone over the edge. So we are on to a food plate because it's a visual picture. I'm like, okay. So you got your fruit and vegetables should be half your plate, the grains, and then the proteins, and then your dairy. So you have exchanges versus carb counting. They're really intertwined, okay? With the exchanges, what happens there is that, you know, you may be giving 2 fruits and a vegetable, and you want to eat 2 grains and then some protein. And so you have to kind of exchange, like, within that group. So, like, the 2 fruits could be a piece of fruit or like a fruit juice. You know, fruit snacks don't count, those nasty things. Oh, my gosh. They're good for low blood sugars because they can, like, survive, like, I think a chemical war, nuclear war. Those things they're all globbed together and stuff, but they still have sugar, right? So that's, you know, so like with the grains, they have like 3 choices of grains. With that, you would have to have maybe some pasta, a piece of bread, you know, something like that, cereal, things like that. So a carb counter, basically what it is, they took the fruits and the grains and the dairy, and they kind of put them together, because if you get the right amount of the volume of the food, you know, the right amount, each, like a glass of milk, a piece of fruit, and a piece of bread, they will all affect your blood sugar the same. So when you're a carb counter, you're trying to group things that are going to affect your blood sugar. So, and with that, so if you've given, you know, 8 carb exchanges, you can have all grains for your 8 carb exchanges, or you can divide it out into fruits, grains, and dairy. Okay, so it just makes it a little bit easier, because, you know, sometimes these kids, they wake up and they just want to have pancakes, you know, and then the battle starts, and the mom's like, oh, no, you need some milk, you need some fruit juice. I just want pancakes. So, you know, battling with food, even without diabetes, you know, is bad, you know, and then dinner time should be a nice social time, not fighting, right? So, so the less you can fight, you can say, okay, you can have your pancakes, but hopefully the next day or the next meal, you know, they'll get some, you know, vitamins from the fruits and some vitamin D and calcium from the dairy. It just avoids conflict, and it gets their blood sugar under control. So really, you know, if you think about it, protein and vegetables are kind of free because they really don't affect their blood sugar. But the kids can only eat so many, like, you know, beef jerky or whatever. They get kind of tired of it, or sausages or pepperoni, but those are relatively free, and these 3 groups are what's going to affect their blood sugar. So, and then the food labels have made life much easier, okay? So one exchange is 15 grams of carbs. So first thing you got to do is look at the serving size. This is a half a cup, and this is probably like a fruit cup. So a half a cup of that gives you 13 grams of carbs. So it's like, you know, 1 food exchange right there, 1 carb exchange, okay? So again, you know, it's sort of our mantra is if you can count it, you can eat it, right? But if you count M&Ms every day, I mean, that you can eat candy. I know people are going to say you can't do this and you can't do that. Well, they can, but obviously if they eat a candy bar every day, that's not healthy, you know. But if they can eat it periodically, they can figure it out, and they can give themselves insulin to cover it, okay? So, but again, the more insulin they get, the heavier they get, and the heavier they get, the more insulin resistant they get. The more insulin resistant they get, they need more insulin. So it's a vicious cycle. So, you know, we say, yeah, you can have your candy bar, but you have to count for it, and you can't have it every day because that's just not healthy. So anyway, because that's the first thing they worry about. I can't have candy anymore, you know, and they're like, you can have candy, you know, everything in moderation. So when you talk about insulin, life has gotten much better for people with diabetes because they have a lot more insulins available that are more physiologic. And the first ones are these rapid acting, the Lispro, Aspart, and glulisine. And they're in and out of your system really around a meal. They're peaking, and they're gone in 4 to 6 hours. The regular is kind of fallen out of favor. That's the 6 to 8. The intermediate, the NPH, again, kind of falling out of favor. But the long-acting, either the glargine or the Levemir, are the 2 24-hour insulins. Okay, so most of them are the rapid acting in combination with the long acting 24-hour insulin is what we use on these kids. But, you know, there's still a place, again, for the NPH and the regular or the rapid acting. So these kids, what they do in the morning is that they give 3 injections, 2/3 in the morning and 1/3 in the evening. And so they take their NPH and the rapid acting in the morning, and that's going to cover breakfast and lunch. A lot of these kids sometimes don't want to get the lunch shot. They just don't want to go to the nurse. So they don't have to get the lunch shot. So then they take the rapid acting at dinner and then the NPH at bedtime. NPH used to be able to give in twice a day, like 12 hours apart. You've got to give the NPH at bedtime because because when you did it twice a day, it was pork NPH, and that did last 12 hours. Now it really only lasts about 8 hours if it's human NPH. So that's why you have to give that at bedtime so it can last, you know, through the night. So again, these kids, the other thing about these kids, they may not want the shot at lunch, but a lot of times they can't figure out how to count carbs. And it's really sad. I mean, because if you're going to get diabetes, hopefully you're good in math because your life is much easier. And if you're not good in math, so what we're going to say is, okay, you have to eat 60 grams every meal at this time. Like we have to put them kind of in a box, okay? And they can't really waver from that. And that, you know, but, you know, sometimes they do real well. Some of the kids, if they're compliant with this, their A1Cs are as good as some other kids. But, again, not a lot of flexibility. This one, though, is very flexible. You give the Lantus, you give that at night. That's your 24-hour insulin. And then you're given an insulin-carb ratio. And, again, with that, you can eat as many or as few carbs as you want. So if you eat, you know, some of these kids, I look at some of these numbers, I'm like 230 grams of carbs. I mean, some of these teenage boys, you know, can really put it away. But sometimes it's maybe 20 at lunch, at breakfast. They don't like to eat a lot. Then they eat a little bit more at lunch and then a lot at dinner. So they eat a lot of carbs. They get a lot of insulin. Few carbs, few insulin. So it's very, very flexible. And it also depends, you know, then you can also not only how much you eat, but when you eat, because you're dictating, because it's such a fast-acting insulin that it's in and out of your system. So if you want to eat 2 meals a day, 3 meals a day, 5 meals, you know, that 5th meal, yeah, those teenage boys can really eat that 5th meal. They just have to count their carbs and give themselves insulin, okay? When you transition to the pump, this is very, very similar to what the pump does, except the pump is just an easier device to give it. The only thing about the pump, a lot of people don't know, there's no Lantus. The Lantus is gone. And that can be kind of a pain in the neck, that Lantus, because you got to give that Lantus every day at like 9 o'clock or 10 o'clock, give or take an hour. And so sometimes that is a little bit trying. But you take the Lantus dose, say if they're on 24-hour, you take the Lantus dose, say 24 units, you divide that by 24, so you would be doing a unit an hour. And you put that in, you program that into the pump, and that's your background or your basal insulin. And so no more Lantus. So again, with this, again, the Lantus is this nice straight, usually it doesn't look that straight, but clinically. But up, you have breakfast, lunch, and dinner. Things are going up. So again, this person ate 3 meals. If they had 5 meals, there would be 5 spikes. 2 meals, 2 spikes. So very, very flexible, okay? And most people, I say, were on this or the pump. So we talked about the honeymoon phase. That's that residual amount of beta cell function. It can last months to years, just like the honeymoon. Eventually it's over, right? So that's why they call that. So you all know. You can measure C-peptide levels, and that's how you figure out whether or not, you know, they continue to have that residual beta cell function left. We talked about the Simoji. That's that insulin reaction. Blood sugar drops down. You have this safety net. Your growth hormone goes up, your epinephrine, your cortisol. Next thing you know, you're high. So anytime you have highs after a low, you got to avoid the lows, and then hopefully you'll avoid the highs, right? And then the dawn phenomenon. You know, what else peaks in the early morning is cortisol. So is it cortisol or is it growth hormone? It's probably growth hormone that causes it. So for adolescents, man, they can have some really high morning blood sugars because they have so much growth hormone being released, okay? A1C is something we measure. Again, it's 90 days. We run the littler kids higher. We like them like less than 8.5 because they can't tell you when they're low. If they can't tell you when they're low, they could have a seizure, right? And it will affect their development. So you run them a little bit higher at 8.5. And then as they get older, you know, eventually teens less than 7.5. Now, if you did blood sugars 4 times a day and you had an average of 150 for 3 months, that would be an A1C of 7%. So they can, a lot of these meters, you know, they can stand on their head just about, you know, and they do a lot, and they can do, you know, 3-month blood sugar averages. And if they're checking routinely and it's 150, then their A1C should be 7%. Every point you go up or down is about an average of 35. So an 8 would be an average of 185, and then a 9 would be, you know, 35 points higher. So, you know, it takes a while. You know, they go down on their, it's a lot of work to get that A1C, you know, down to the 7%. But I have a lot of kids that do it, and they're just compliant. They just do their best, and they have to be on it every day. Signs and symptoms of new onset. This is a, you know, a good board question. First, you get the polyuria, because once your blood sugar gets over 180, it starts spilling into the urine. So they start going to the bathroom a lot, or if they start wetting the bed at night when they hadn't done that. So then you're getting dehydrated. So then you get the polydipsia. You drink and drink and drink. They have this like unquenchable thirst, gallons. Okay. Then you get the polyphagia. You're really hungry because you're losing thousands of calories in your urine. Hopefully teenage girls never figure that out, because then they aren't as compliant because they want to lose weight. But you lose thousands of calories in your urine, and they start losing weight, and then they start throwing up because they, you know, once you stop using your glucose as a source of energy, you start using your fat, right? And you start breaking fat down. So the ketones and the acidosis start building up. So emesis in a kid with diabetes is acidosis until proven otherwise, okay? So that's very important. The parents know that. Kids with diabetes cannot throw up, you know, unless they check their ketones. Then you can make sure. I mean, obviously they can eat bad egg salad or something, you know, and get sick from that. But, you know, the first thing that they should do is check their ketones and make sure they're not getting acidotic. Long-term complications, neuropathy. I don't see this very much, thankfully, but the only treatment, best treatment, is improvement in diabetes control. ACE inhibitors don't help. And as they start improving their controls, they get regrowth, and it can kind of hurt more before they get back under control. Retinopathy, that's something we screen for, again, with type 1s after 5 years, with type 2s at diagnosis. Okay, and same thing with nephropathy. Type 1s after 5 years, type 2s at diagnosis. But we're more aggressive, and with the look for microalbumin, you know, just a little bit of protein, you got to be very aggressive for checking for that every year, and then step in with an ACE inhibitor. And that has really decreased the incidence of nephropathy in these kids with diabetes. Celiac, that's something, that is just, I'm not quite sure I understand celiac. I mean, it's out there, and you look for it, and then you get the diagnosis, and it's just really becoming more popular, and people becoming more aggressive with it. And so our job is to check the antibodies. And then we send them over to the GI docs to actually look in their gut. But it's about 1 to 16% of all patients with type 1. It's definitely more common if they get diagnosed with type 1 before age 10. So the ADA, again, they want you to check, and they have multiple recommendations. Check it after celiac. Check for celiac soon after diagnosis. Check again if they're having growth failure, failure to gain weight, weight loss, or GI symptoms. And they also recommend, quote, considering rescreening in asymptomatic individuals. So we screen usually once a year and do their annual exam. And if they have the antibodies, then we send them to the GI. Just because they have the antibodies doesn't mean they have the disease. Kind of like with Hashimoto's. You can have the positive antibodies but not necessarily have thyroid disease. But we let the GI folks figure that out. Sick days, these kids with diabetes do get sick, and it makes their blood sugars go crazy, okay? And so we try to avoid them from coming in. So we're on the phone a lot, you know, during the day with these kids, and the parents will call. So again, the first thing they got to know is that if their blood sugar is greater than 240, they have to check for ketones. Because at that point, they're no longer using glucose as their first source of energy. They're starting to break down fat and then potentially getting the acidosis. So basic treatment is fluid and insulin. That's what they need. Now, if they call up and they're throwing up, they have to come in. Nobody ever wants to come in. You know, some of my colleagues will use some antiemetics, you know, some Zofran or whatever. That doesn't make their acidosis go away. And these kids would rather not come to the ER. So I don't give out that. And once they know that they're fine, we can give it, but they have to come in to make sure they're not acidotic. Change in mental status, if they're dizzy in spite of oral hydration, if they've had moderate to large ketones, and we've been working with them all day long and they're not getting better. Fever, infectious symptoms, an unreliable family, which are deep, rapid respirations, they all have to come into the emergency department. So again, you need insulin, you need fluids. So the insulin, they're resistant because of the acidosis and the poor perfusion. And they're stressed, right? Got these stress hormones going. And what's happening with stress hormones? They increase up gluconeogenesis and glycogenolysis. So their blood sugar is continuing to go up. And the thing that makes me crazy is when I hear from parents and sometimes residents and sometimes ER docs and colleagues that, oh, they're not eating, they don't need insulin. They have diabetes, they don't have insulin. They always need insulin, okay? Because even though they're not eating, they're stressed and their glucose levels are going up. So not only do they need insulin, they need more insulin because they're acidotic, okay? And the other part of the equation for the treatment, you got to drink water. You're getting dehydrated. You got to keep up with your fluids. So again, if you're throwing up, half of your treatment plan is gone, so they have to come in. So again, it's fluid and glucose. So what do we do? So again, they call you up, the kid's sick. What are the ketones? I don't know. You know, I don't like to pee on that stick, or we expire. They have every excuse in the book. I'm like, okay, you need to get ketone strips. They can just go to like CVS and get it. So get the ketones, and if they're on a pump and they're getting this, they got to change the pump site because it's not delivering insulin. You got to take the pump site out, give themselves a shot, and put it back in. Okay. So every 3 hours or so, we're talking. We're checking glucoses. We're checking ketones. We're telling them to drink fluid, again, about 8 ounces an hour while awake. And they need about 15 grams of food an hour. And when you're not feeling well, what do you like? Ginger ale, you know, Coke, you know, Sprite, something like that. If that's all they can keep down, that's fine. They can take regular sugary stuff. That would be part of their 15 grams, and then potentially part of their fluid. Now, the insulin, everyone thinks like we have this magic formula, you know, for insulin. How much do you figure out? Well, what we use is this rule of 1,500. If you take 1,500, this is what we use on the pump, and you can use it for kids on Lantus and or Levemir with, you know, the Glargine, the Novolog. Total insulin divided into 1,500 kind of gives that person their sliding scale. What does that mean? So if they're on 10 units of insulin, you divide that, so 10 into 1,500, that's 150. 1 unit will bring their blood sugar down 150 points. If they're on 100 units of insulin, 1 unit will only bring down 15 points. So so the more insulin you're on, the more resistant you are. And that, again, determines that person's sliding scale. Okay, and that's what we do. But every 3 to 4 hours, we're talking. And then hopefully by the end of the day, they're better. If they're worse or they're throwing up, they have to come in. Okay, some hypoglycemia. 3-year-old presents with seizures due to hypoglycemia. She'd been well until yesterday when she started to have acute gastro. She has not eaten well since yesterday morning. Her blood sugar is 35. Which labs need to be drawn to determine if it's due to exogenous administration of insulin? Insulin and C-peptide, insulin only, C-peptide only, insulin and proinsulin, or insulin and ketones? And put your answers in. Very good. So the answer is insulin and C-peptide. Again, in the bottle, it's only insulin. But if it's, you know, being made, you know, you got the pre-pro-insulin and the pro-insulin, and then you get insulin. And when you cleave that off, it's that C-peptide, that connecting peptide that connects the alpha and the beta subunits of the insulin. So that's when it's made from the inside. Made from the outside, it's only the vial. And so it only have insulin in it. So very good. So hypoglycemia, depends on the blood, how you got the blood and how old the kid is. So if it's whole blood, you know, the bedside glucose that you're checking, it's going to be a little bit lower because red blood cells will metabolize some of that glucose. So preemies can go down to 20, 25, it's from the serum or in the lab. Then full terms and any other kid, it's 40 and 45. So make sure you know the source of the glucose that you're testing and the age of the child. So this is kind of a busy slide, but when you get hypoglycemia, and everyone just kind of freaks out, okay? And I can understand that. And it is complicated, but most important thing you're trying to differentiate is the presence or absence of acidosis, and in my mind, really the presence or absence of ketones. Okay? So if you look like this list is a little bit shorter. I like memorizing the shorter list, right? And everything else is longer. But if you have no acidosis and no ketones, either it's too much insulin or fatty acid oxidation disorder. You can't, break down your fatty acids, okay? All the other ones have normal and elevated ketones, okay? So we'll break this down a little bit and talk about the more common ones that you'll see and the ones I think that you'll potentially see on your boards. So when you see these kids, the most important thing, they're in the ER and this happens, and they're in the ER and they're seizing, and it's very scary when they're seizing and everyone's trying to stop the seizure and get the blood sugar up. But that's great, but you got to get this critical sample, Somebody else should be trying to get blood while somebody else is getting the blood sugar up. Because this critical sample, I always say, don't call it critical for nothing, because if you don't do it, then then they say, oh, we have to send them to endocrine because their blood sugar was low. We have to fast them. We have to bring them in and we let them sit in the observation unit for 12, 24, 36 hours potentially and not feed them. We are not the most popular doctors at that point, okay? And so hopefully it'll be, they'll have a low blood sugar and then we can get the sample. But again, the critical sample, and what you're trying to do is trying to figure out that wiring diagram. Where do they fit, okay? So chemistry panel looking for the acidosis, obviously the glucose, the insulin and C-peptide, because Munchausen by proxy, unfortunately, is out there. The cortisol and the growth hormone, making sure their counter-regulatory hormones are working. And the free fatty acids, the beta-hydroxybutyrate and the acetoacetate. Can they use, again, first line is glucose. When you're done with your glucose, you got to start breaking down your ketones. That's the normal pathway of starvation. And so you got to figure out, can they go down that pathway? Are they breaking down their fats appropriately? And these other ones are more inborn errors, which aren't as common. So probably, from here above is the most important. Always want to get ketones, whether that be in the blood or the urine. And that saved tube, we used to call that the digitubes, when I was a resident. Because the next morning, the staff person would come on and they would say, well, did you get this or did you get that? And we would just have serum that was held. And we're like, oh, yeah, we got it. And we'd run to the lab and order it up. So the digitubes, yeah. But again, if we don't get it, we gotta fast them, which is never very fun. So again, things you got to know for hypoglycemia, hyperinsulinemia. And the most common thing is if you're on insulin and you underestimate or how much you ate or you overestimate your insulin requirements, you're going to get a low blood sugar. So that's the most common. But the Munchausen by proxy, again, unfortunately, is out there, and I've seen it a number of times. Munchausen's when you give it yourself. A lot of teenagers, they don't want to go to school. They give themselves too much insulin. Or Munchausen by proxy when somebody else is giving them the insulin. Endogenous insulin in kids is pretty rare. In adults, again, you get insulinomas. In kids, that newborn nursery, when you get that nocidioblastosis or hyperinsulinemia, that's about the only time you're going to see it. Otherwise, you don't see it in kids, any sort of an insulinoma. So again, exogenous, outside the body, in the vial, they're going to have high insulin and low C-peptide, okay? And then endogenous, inside, high insulin, high C-peptide, okay? So again, it's not a set number. But, when you go in, your insulin level is, 300, and your C-peptide is normal, they got it from the vial. So that's probably one of the more important ones you can get. The other thing that you're going to see, this is a general pediatric problem, really, and so it's common. You're going to see this one. This is ketotic hypoglycemia. And the classic presentation is kind of a lean 18-month-old to 5-year-old kid, kind of not a lot of muscle mass, just kind of one of those skinny little kids that run around, healthy. They get an acute illness the day before. They fall asleep around 4. They sleep all night. They don't eat dinner. And then they sleep through breakfast. So they've missed dinner and they've missed breakfast, and they hadn't missed any snacking that they normally do. Their glycogen stores are gone, okay? And so what do? That's really kind of a normal pathway of starvation. So they come in at 10 o'clock and they have a seizure, okay? So again, no glucose and no glycogen stores, so then they start breaking down their fat and they get ketones. And this lack of alanine is what's needed for gluconeogenesis, and you get that from muscle mass. So if they don't have a lot of muscle mass, that's the theory, is that they can't produce any more glucose because of the lack of muscle mass. So again, this is really sort of a normal state of starvation. The kid comes in, and you give them some glucose and they do fine. But they are at risk for getting this again if they get sick. So you got to make sure that the parents are aware of that, and that if they are just kind of getting not feeling well and not eating, they can do this again, so they have to come in to get some fluids. But common board question right here, and common, you'll see this a few times a year potentially. So to make sure you understand that one. So acute therapy, if they're awake, it's the rule of 15. Eat 15 grams, wait 15 minutes, and check blood sugar again as needed. And again, whatever is available, okay, you want to get that into them. And food labels are helpful. Now, if they're unconscious, this is when you have to use the glucagon. And it's amazing that the years I've been doing this, we ask these parents to do a lot, but for some reason they just don't like to give glucagon. One of the things is some way that they make it is that it's in 2 vials. And so first of all, the kid's seizing, right? Like, oh my gosh, they got to remember where the glucagon is, okay? And then they find the glucagon. Hopefully they have the syringe. I usually have them tape the syringe to it. So then they do that. So then they got to open up both vials. They got to take the fluid out, which is just a diluent. They put it into the powder, which is the glucagon. They shake it up. They give it, again, their kid's seizing. Everyone's screaming. Everything's happening. They're doing all this, and then they give the shot. That's a lot to ask, So they often don't do it. And if they do it, they just give the diluent because they forget. So darn it, they get so close and they didn't quite do it. So you give them some kudos for trying. And anyway, so you want to talk about glucagon all the time. Now, they do have pens that are available that, kind of one of those, it looks like an EpiPen, or anyone in the military, the pens that you would use out in the field, where the glucagon's on the bottom and the dilutant's on the top, and as you're pushing it in, it kind of mixes and gives. So that makes life a little bit easier. But the one thing about glucagon, it can make you throw up because it's a GI hormone. So the kid's sort of semi-conscious or out of it. Make sure you're watching their airway if you're giving it. Schools don't always like to give it either, but make sure that they can have it on board, and they call 911. And they also need appropriate glycogen stores to work because that's where it works. So we had this one kid at camp, and she truly passed out. She was a teenage girl. She was working a lot harder than she normally did and didn't eat as much, and she had a seizure, and we used glucagon. And then when she woke up, she was like, oh, look at all the boys paying attention to me. So she decided that I'm going to do this again and again. Yeah, and then it takes good 12 to 24 hours to get the glycogen stores back up. So after 3 or 4 times, in the next few days, that it wasn't working because she didn't have the glycogen stores for it to work. So anyway, so that's that. So watch out for the throwing up. The second question, this is a good board question. If you have a kid that's having a seizure in the hospital with low blood sugar, give them IV glucose, because you have to have an IV, obviously. I mean, if you have an IV, that's the best way to do it. And again, it's not an amp. It's not D25, D50. You're not playing ER, on TV. It's like 2 cc's per kilo of D10, just this little weenie dose. That's all they need. Because, oh my gosh, if you give like an amp of it, their blood sugar goes like to 1,000,000, and it takes forever to get it back down. So just 2 cc's per kilo of D10, that's all you need. Puberty. Actually, I think puberty is fascinating. It's probably one of the reasons I do endocrine. It's just sort of a fascinating thing how the hormones change, from birth through adolescence. And so, and there's also a ton of questions on puberty because it covers both normal and abnormal and then adolescent stuff. So make sure you understand the puberty. And again, I'm going to give you the tools to figure this out. So first question, 8-year-old boy presents for a routine exam. He is Tanner 2 pubic hair and 5 cc bilaterally descended testes. The immediate test that needs to be ordered is a testicular ultrasound, a brain and cell MRI, a bone age, an adrenal CT, or a testosterone level. So you can go ahead and put your answers in. Okay, we got a little gamish. We got between brain and cell MRI and a bone age. So the people that picked the brain and cell MRI, okay, very good, because this is a brain tumor 50% of the time. Okay, so a boy that has precocious puberty is a tumor 50% of the time. So you've got to go right to the brain and look and do an MRI. A girl, it's only about 10%, so you have a little bit more time and you can do some other testing, but a boy has got to go right to an MRI, and we'll talk about this multiple times. But again, clinically and for the boards, it's very, very important that you understand that. So again, normal pubertal development. In utero, the levels start, the GnRH, FSH, LH, start peaking at around 20 weeks, and then the baby has their feedback loop, and the levels start going down. Some of the levels are going down also, the negative inhibition, because of mom's hormones. Okay, and then, you know, the cord is cut right there, and then the levels go really high, like really high. Like the levels at birth, you know, can be as high as pubertal levels, and that could be normal. So again, if you're working up a kid in the nursery, maybe with ambiguous genitalia, and you get some testosterone levels that are, ooh, those are really high, that could be normal. So it's important that the lab that you're dealing with breaks them down according to their age, and they understand that. So levels are up, levels are down, and then there's some sort of negative inhibition that makes the levels go down, and over time that weakens. And again, what that negative inhibition is really unknown. Something's dampening the GnRH response there. GABA proteins, neuropeptide Y, endogenous opioids, melatonin. There's a lot of theories out there. Don't quite know what it is. But the important thing that you guys understand is that if you are inhibiting this negative inhibition, puberty starts early. Okay? So congenital kids whose brain, you know, congenital CNS, kids that are developmentally delayed, have other issues, they often will go into puberty early because that negative inhibition, again, whatever it is, isn't quite set up normally, just like the rest of their brain, unfortunately. But acquired CNS problems, the brain tumors, that's the thing you got to pick up, because early puberty, a brain tumor 50% of the time in a boy and 10% in a girl. So another thing about puberty, it's important to understand there's two parts that have to happen. Okay, you got to get your gonads working and your adrenal gland. And the kid's going to tell you when you go in there, like, what's going on. You got to know the clinical clues to figure out, do I need to go down the gonadal axis, the adrenal axis, or is it both? Okay. So triggers, not quite sure what triggers puberty, but stress, fat, weight, genetics definitely plays a role. Okay, so you do want to ask, especially with the little girls, when did mom start their cycles? And that's usually about the only thing they remember. And the dads have no clue as to when anything ever happens. You know, it's like, were you there? You know, they don't have any. So sometimes the only thing you can tease out of them is like, did you grow after high school? Because that's usually mean that they're a late bloomer. Okay. And the BMI, the higher BMI, that will initiate puberty sooner in a girl, but not in a boy. So it's interesting. You see these kids come in, these girls, and their BMI's up, and you're talking to them, and you're counseling them. Oh, my God, they're at risk for diabetes, and you're at risk for blood pressure problems, you're at risk for cholesterol problems. The parents are sitting there rolling their eyes, whatever, and then they can go into puberty too soon, and they're like, oh, my gosh, you know, that's like the only thing they pay attention to. So that's sometimes, you know, you can use that in your counseling. The good board question, which gonadotropin goes up in puberty? It's the LH. You get LH spikes in the middle of the night, and that's what starts puberty. So again, puberty, normal pubertal development. For the breasts, again, this is Tanner 1. There's no breasts. Tanner 2, a little breast. Tanner 3, a little bit more breast. So it's kind of hard. Tanner 4 is easy because there's 2 mounds, right? And that's Tanner 4, and that's an important one because that's when menstrual cycles start. Okay? So I think this is obviously easy. This is easy. This is easy. 3 to 5, it's kind of hard, you know, because, you know, a 3 for somebody may be a 5 for somebody else, you know. But so it's the 2, okay, because it's about your body fat, right? Breast is all body fat. I mean, percentage of it, a lot of it is your body fat, so that will play a role. But this is the double mound, so you get the areolar and the breast tissue, and that's Tanner 4. and that's menses. And the board loves to ask questions on different pubertal milestones and what would be going on at what Tanner stage. Okay, so, and then the hair, again, no hair, lots of hair. You know, this is just peach fuzz. And they're like, peach fuzz? I'm like, that's hair. That's vellus hair. That shouldn't be there if it's too soon, okay? So, and then they start getting the pubic hair. But again, I think the important thing, again, we'll talk about the different milestones and what happens at different pubertal milestones. And that, again, lots of board questions can come there. So again, first thing we're talking about normal male. Again, you got the gonads and you got the adrenal gland. Okay, so you got to think of that. Two different things. First thing that's going to happen is your gonads, both for the boy and the girl. So the boys are the testes. The hormone is testosterone. The gonadotropic axis, you know, the gonadotropins start going up. So your FSH and then specifically your LH start spiking, goes to the testes, and then they wake up. And how do you know the testes are waking up? By the size. Okay? And everyone's like, I don't have any of those beads. Well, you don't necessarily need the beads, you know. So you don't necessarily need the beads. You just get out a little, you know, they look at you kind of crazy, but, you know, you just, it's 3 cc's in volume or less is prepubertal. And that's a length of a testes of 1 inch. So 1 inch or less is prepubertal. Anything after that is pubertal, okay? So they always love asking this kind of question. The first sign of puberty in a boy is testicular enlargement, okay? And the testosterone is released, and eventually you're going to have the body odor and the acne and the pubic hair and the axillary hair. Then the adrenal gland starts working, and this is, you know, fascinating. Why, you know, again, you have your GFR, right, your glomerulosa, your fasciculata, and your reticularis, right? So your salt and your sugar and your puberty hormones. Like, so from birth, you know, the salt hormones, the mineralocorticoids work, and the glucocorticoids work, but the puberty ones don't. And it seems like there is a growth of that last axis as, you know, puberty starts moving along in the adrenal gland, in the adrenal cortex. And what controls that is unknown. Again, the mineralocorticoids are the renin-angiotensin system, and then the glucocorticoids are ACTH, and then the pubertal hormones, adrenal hormones, who knows? It just starts working, okay? But you got androstenedione, DHEA, and testosterone are the 3. And again, that makes your androgen effects, your, you know, the lovely effects of puberty, the body odor and the pubic hair and the axillary hair and the acne, okay? So that's how it divides up in a boy. So it's very important. So if you're going to get this kid coming in, you get a lot of kids coming in, a little boy with pubic hair, okay, say a 5-year-old with pubic hair. So he obviously has androgens on board. So then your question is, where are they from? Well, if you look at the testes, and it's 3 cc's or 2.5 centimeters or 1 inch or less, it's not the testes that's doing it. It's still prepubertal. It is not releasing the androgens. So you're like, okay, I don't have to worry about the testes. I don't have to worry about the gonadotropins. I don't have to worry about the pituitary gland. That whole part is, just by looking and examining that kid, you can say, I don't need to worry about that. I have to worry about the adrenal gland because that's where it's coming from, and you got to work that up. Okay? So now, if you look at the testes, and the testes are pubertal, then it's precocious puberty, okay? So precocious puberty, when you talk about puberty in a boy, the only thing you need is for the testes to start working, okay? So just the testes working is puberty. For a girl, you need both the gonads, you need the ovary and the adrenal gland to be considered puberty. But for the boy, it's just the gonad has to start because 50% of the time it's a brain tumor. So we don't like, that just scares the bejeebers out of me. So you don't let that, you know, go any further than it has to, okay? So that's very important. So you identify androgens, and just by measuring the testes, you're going to be able to figure out if it's from the testes or from the adrenal gland, okay? So the first sign is testicular enlargement. Peak growth velocity, a good board question, Tanner stage 4. Axillary hair 1 to 2 years later than pubic hair. Now, as far as the size of the testicular volume, the majority of it's going to come from the seminiferous tubules. And when you talk about Klinefelters, you know, they have dysgenesis of the seminiferous tubules. That's why their testes are small. Okay, lots of kids get gynecomastia around Tanner stage 3 to 4. And it takes 2.5 to 5 years to complete, to go from like Tanner 2 to Tanner 5. So the girls, similar, but obviously a little different because their gonad is the ovary. and the ovary makes estrogen. Again, the hypothalamic pituitary axis, the gonadotropins start being released, and then you start getting the estradiol. So clinically, great board question, the first sign of puberty in a girl is breast development, and eventually that's going to have menses. The other thing that starts is the adrenal gland. Similar to the boy, DHEA, androstenedione, testosterone, unknown control. But from that, you're going to get the pubic hair, the axillary hair, the body odor, and the acne. So you get a bunch of kids in your clinic that morning, and the first kid that comes in has hair but no breasts. You're like, okay. So you look and you examine it, yep, no breasts but hair. So you need to go down the adrenal axis. You have to worry about the adrenal gland. You do not have to worry about the ovary. You don't have to worry about the gonadotropins or the gonads, just the adrenal gland. So your differential is CAH, adrenal tumor, Cushing's, premature anarchy, or external exposure. And we'll talk a little bit more about that later. But again, adrenal side. Next girl comes in, breasts, no hair, okay? I mean, very simple, but it's very clean cut, especially in a little girl. So breasts, okay, and you examine them, and there's breasts, but there's no androgen effects. So you just have to worry about the ovary. You have to worry about estrogen, FSH, and LH. You're just down that axis, okay? So I always, when the residents work with me, I said, which axis are they? Are they on the gonads or the adrenal? And they'll tell you by your exam, okay? Precocious puberty, though, is both for a girl. Hair and breasts is precocious puberty, and then you got to work them up for that. And is a tumor 10% of the time. So again, first sign of puberty in a girl is breasts. Great board question. Menarche is about 2.5 to 3 years later, okay? So that's usually what parents are worried about, right? You know, you say the child's in puberty, and you have to pick them up off the ground, and then, because they're worried about periods, right? But you give them some time. You got 2.5 to 3 years between the breasts and the periods. Peak growth velocity a little bit earlier in girls, 10 or 3 to 4. So by the time they've had their menstrual cycle, they've done about 90% of their growing, 80 to 90%. So they're definitely on the tail end, like 2 to 3 inches. Funny story about my daughter. She started a little bit on the earlier side. I'm obviously tall. I'm 5'10". My husband's 6'2". And so she was moving along, and she was only like 5 foot when she had her period. And I'm like, oh, my gosh, she's only 5 foot. She's only going to be 5'2". That's the first thought that I had when she told me that she had her period. And so anyway, she ended up to be 5'5.5", so that's a nice size. But I was like, Katie, I don't think you're going to be very tall. And so I said, you're not going to be as tall as me. She goes, nothing personal, Mom, but I don't want to be that tall. I was like, okay. So, yeah, so it's funny. I was first thing as an endocrinologist, oh, my gosh. So anyway, now I see a lot of these kids. They come to me for vaginal bleeding, okay? And I look at them, and they're like 10 or 2 breasts. Like, you don't have enough estrogen on board to have vaginal bleeding at 10 or 2 breasts. So there is something going on which is not endocrine. You know, you have to worry about child abuse or something else that's going on. So, I mean, I'll do their hormone levels, and I'll say they're fine, but then I send them to a GYN doctor for an exam to make certain that everything is okay down there. So that's a good board question. You know, menses at 10 or 2 breasts is not menarche. Okay, it's vaginal bleeding, and the list is very long, and possible menarche is like one of the last things on it. Okay. So make sure you get those kids to the right. They need to go to a GYN doctor for a complete vaginal exam. So variants of normal, there are 3 variants. There's premature thelarchy and premature adenarchy. Very, very common sort of thing. So these kids come in, and they're little girls, and they just have breasts, okay? Just breast development, and that's it. You know, 6 to 7 years of age or less. Sometimes they'll come in, they'll say their chest hurts. I mean, because as the breasts are getting a little bit bigger, it's kind of painful. So they'll complain about chest pain, then you look, you're like, oh, they just have those little knots underneath their nipples. And so, but anyway, just breasts, no hair, no body odor, no acne, nothing else. If you do an x-ray of their hand, they have a normal bone age. If you do hormone levels, they're prepubertal, okay? So they're fine. It's just, again, a variant of normal, but a diagnosis of exclusion, because if they have breasts, they potentially have estrogen. And then your question is, if they have estrogen, is it abnormal? Do they have a tumor? Are they just starting puberty? Or are they getting some exogenous estrogen exposure from the environment? So that's one of the things. You got to ask questions. First thing is like, how much phytoestrogens do you get? That's soy products, okay? Now, there's a little bit of soy, and there's like, well, I see Yellow Spring soy, which the only two Dayton people here would understand. Yellow Spring is kind of like Berkeley, but it's in the middle of Ohio. It's really weird. But they, you know, they're from Yellow Springs. They drink a lot of soy and soy burgers and soy milk and a lot of soy. And I've had a few kids whose estrogen levels were really high, and it's not, you know, just a little bit of soy formula. They have to take in a lot of soy. Other things they can get estrogen from, hair products. And that's not as common anymore because it's been identified. But hair products are not FDA regulated, so they can really put whatever they want in them. And African-American population will often use hair grease or hair food to put in their hair, and they have placental products in it, which has some estrogen in it. So it kind of freaked the parents out. And so then, but that has been well documented. And again, not as popular since it's been documented, something you want to ask for. Estrogen creams, like if you're going to have a vaginal adhesion and use estrogen, that can cut enough into the system that can cause breast development. And birth control pills, just making sure that there's no birth control pills at home that the kids could be getting into. On your exam, obviously, you're going to look for growth velocity. You're going to Tanner stage them. You're going to make sure, again, that the adrenal axis is not being involved. And you're also going to do a skin exam looking for McHugh and Albright. That's the thing with the big cafe au lait spot, the polyostatic fibrous dysplasia, and then usually precocious puberty, because they can start with breast development. So, okay, so you see it. So you got all you got is the ovarian axis, right, the gonadal axis. So you're going to do the gonadotropins, the FSH and LH. You're going to do the estradiol, and you're going to do the bone age. And that's it, okay? You don't just, that's all you need at that point, because that's all the kid is telling you. That's all the kid is showing you. And then you monitor them every 3 to 6 months for a year or two, just making sure that they don't go into puberty, okay? Obviously, if anything's abnormal in the initial screen, you're going to do an MRI, an ultrasound, or maybe a GnRH stim test to look for precocious puberty. Premature Anarchy is another, again, variant of normal, but diagnosis of exclusion. And what's happening is that the adrenal axis is beginning to be activated, but the gonads are not involved. So it could be in a boy or a girl, again, body odor, pubic hair, axillary hair, or acne. Less than 8 in a girl and 9 in a boy. But again, there's no breast, there's no gonadal development or in the girl, and the testes are normal size or prepubertal size, so there's no gonadal involvement with the boys either. Prematurity, a lot of premature kids will get this. You know, history of prematurity, they'll have this. Heavier kids and kids with, you know, again, developmental delays, they'll often have premature anarchy. But they go on to be normal, except now there's this like, body of literature is like, are these girls at more risk for polycystic ovarian syndrome? There's a lot of research being done, and I always tell the parents that, and I said, we don't know who is and what to do about it, but we know that there is a little bit of a risk factor. So if she starts adolescence and starts having some of the signs and symptoms of PCOS, she should get that evaluated. You know, maybe when her daughter is old enough, they'll have a better idea who you really watch and who you don't. But that body of literature is out there and just saying premature anarchy, worry about PCOS. So again, androgens on board. So your differential is too many androgens. Not a big, long list, to be honest with you. CAH, like a late onset CAH, an adrenal tumor, gonadal tumor, Cushing's, and then environmental exposure of androgens, okay? So this is interesting. This is relatively new stuff. Androgen, you know, guys that are hypogonadal as adults, they used to use patches. So they'd have the gel and they have a patch and they'd put it, and the patch kept coming off and it would itch and the people didn't like it. I mean, I'm sure they liked the extra testosterone, but they didn't like the side effects. So they came up with gels. So all you do is you take the gel and you wipe it on your hands, and you usually had to put it on your chest or your back. Okay, so now you got all this androgen on your hand, androgen on your chest, and you pick up your little baby, and you're like, oh, what a cute baby, and you put him on your chest, and you're, you know, patting the back, and next thing you know, you got like a little gorilla on your hand. The baby's like, it has this hair, and they're like, oh, that's not good. So then they decided that they have like volumes of instructions on these things now. You know, make sure that when you put it on, you wash your hands really well, and then you put a T-shirt on, and then so nobody else gets exposed to it. So I had one kid I was trying to, he was hypogonadal, he's going to need testosterone replacement, and we were talking about this, and he was kind of really freaked out about it. Mom kind of liked it, so she goes, well, if his girlfriend starts getting hairy, I know that they're fooling around. And I said, exactly. So he went for the shots, and those testosterone shots hurt like the dickens because they're oil-based, and they got to last, the whole month. So, no, he didn't want any cream on his skin. But, yeah, that's a relatively new, something new in androgens, so make sure you know that. So, again, androgens. So here they are. They have too many androgens on board. What are you going to get? Androgens. You're going to get the DHEA, androstenedione, testosterone. And the 17-OHP is a screen for the late-onset CAH. Notice there's no gonadotropins, there's no FSH and LH because the gonads aren't working, so you don't get the labs. You don't need the labs, okay? And then a bone age. And every 1 to 4 months for a year or two, making sure they continue to be stable. If there's any abnormalities, if the androgens seem real high, we'll do an ACTH stim test to rule out CAH or imaging to rule out a tumor. Again, and then we talk about the testes. Again, no such thing as premature testilarchy, right? There's adenarchy, a thelarchy, but testilarchy, no. A testes that's getting too big prior to puberty is abnormal and needs to be evaluated, okay? So 50% brain tumor. So I beat that dead horse there, but. So precocious puberty, it used to be kind of easy. Before age 8, you got to know the times, okay? 8 in a girl, 9 in a boy. And if it's too late, it's 13 in a girl and 14 in a boy. But around in the middle 90s, there was a lot of workup for these girls that were going into puberty too soon, and everything was normal. And so the Lawson-Wilkins Pediatric Endocrine Society said, no, maybe the dates have changed. It's 6 in an African-American girl. We're talking breast development, okay? 7 in a non-African-American Caucasian, and still 9 in a boy. That hadn't changed. I'm sorry, 6 in African-American, 7 in Caucasian, 9 in a male. Again, that's just breast development. And that has been debated back and forth. Well, they had a really good study, 17,000 girls they looked at. That's a huge N, and they decided that, they were just starting breast development and puberty a little bit sooner. And again, not 100% accepted. Sometimes it's really hard to tell, right, on an exam. Is that breast tissue or is that adipose tissue? And menarche hasn't changed. Menarche is still around 12, so how come that hasn't changed? And are we going to miss something? So depends. I mean, it depends on your endocrinologist. Some of them stick with the old definition. That's the way they learned it, and it's good enough for me. It's good. You've heard that before, right? So I'm just going to stick with that. Some of them will use the newer. But probably what they should be doing, because they came out with another recommendation for that gray zone. The girl that's between 6 and 8 and have started breasts. So he probably should evaluate them if the puberty is rapid. This is the Lawson-Wilkins again coming out saying rapid neurological problems. Again, remember that brain tumor. Bone age is advanced greater than 2 years because you're going to start losing height and height potential. Predicted adult height for usually in the girl, less than 59 inches, and then the family's concerned, which is like all families. So everyone gets evaluated, right, between the 6 and 8. So at least do a bone age on those kids and do a good exam, and then potentially some hormone levels. But that's the recommendation. Everyone says, oh, they're going to ask a question on this. I'm like, it's so controversial. I don't even know what kind of question you can ask, except is the beginning of puberty controversial in girls? Yes. I mean, that's the only question I can come up with. So just so you know. Okay, so again, have I said this? Brain tumor, 10% in females, 50% in males. This is always a good question. The most common type of tumor is a hypothalamic hamartoma. And what is that? That's a bunch of GnRH, like in a little mass of stuff. And they start releasing GnRH and inappropriately, and you start puberty. Again, they use the word, we get these kids coming in, chief complaint, precocious puberty. And it's really premature, it's really adenarchy. Or precocious puberty, and it's really thelarchy. So if you use the word precocious puberty, again, for a girl it has to be both the gonads and the adrenal gland. But for the boy, it's just the gonads, okay? And how do you treat them? Well, you treat them with Lupron. You're like, and that's GnRH. You're like, okay, that doesn't make any sense. Because GnRH, FSH and LH, the gonads. So that's going to drive the whole train, right? And so why the heck would you use something that's going to drive the train? Well, how you use it. Because what happens, everything in endocrine is cycles up and down, up and down, up and down. So with Lupron, it's a huge dose of GnRH. And you got to parents, everyone wants to go home and read on the internet and stuff like that. So One thing you have to tell them is like Lupron's also used for prostate cancer. So when you go up and you say, Dr. Pfeiffer wants to use this medicine to get prostate cancer, well, yeah, it's also used for precocious puberty. But the other thing, the way that it works, because it's a huge bolus, your body will respond to it initially. So often they can have a period. They can have a cycle after the first injection. So that doesn't make them happy. So as long as they're aware of it, you know, we're supposed to be avoiding the periods, and all of a sudden you give my daughter a period, and they're not so happy. But then the second dose, the shot, your body sees that huge bolus of it, and all the receptors just downregulate, and so then you stop. So the first time you get the shot, you can have a period, but after that, you don't. And again, basically, the Lupron's a shot every month. There's one that's out now for 3 months, but you can't regulate it as much. And there's something called Hysterline, which is an implant that you can use for a year, which avoids the shot. So once they're kind of stable, you can go to that, but as you're trying to figure out the dose that they need. And then you treat them until they're ready for puberty. And these parents are trying to negotiate. How about 15? I'm like, no, how about 10? You know? So usually you stop them when they're kind of ready to start having a menstrual cycle, usually around 12. So if they're like 10 or 3 to 4, and you know, once you stop that medicine, you know they're going to have a period. Usually you'll go to about 12. But if you're keeping them pretty steady at 10 or stage 2, usually you stop at around 10 or 11. So, but yeah, these parents do not want to stop that medicine. The kids want it because it hurts. I mean, it's an IM shot. But so syndromes, lots of syndromes. I can't emphasize enough how important syndromes are. They're easy board questions to make. So get your 3x5 cards out, and so write down the syndrome and what's on the back, and for everything, you know. And so you'll have a huge pile, and that's going to give you a number of board questions and answers. So first syndrome we talked about already, cafe au lait, polyostatic fibrous dysplasia, and this autonomous endocrine hyperfunction. G protein is a protein within each of your cells that activate it, and that's activated. And basically the glands are working independently. There's no feedback to the hypothalamus or the pituitary. And that is McHugh and Albright. So they come in, this huge cafe au lait spot, okay, usually. And then the polyostatic fibrous dysplasia, this sort of moth-eaten sort of bone. Sometimes they'll have a pathologic fracture through it, but a lot of times you just do a bone scan or a bone survey and you'll see it. And again, there's independent, there's no feedback, independent. Usually it's puberty, but you can see thyroid, you can see growth, you can see ACTH, but usually the classic one is puberty. Delayed puberty, we talked about, again, important definitions. This hasn't changed. 13 in a girl, 14 in a boy, or more than 5 years have passed between beginning and ending. So the differential diagnosis, the big long words, hypergonadotropic hypogonadism. So the gonadotropins are really high versus hypogonadotropic hypogonadism, where the gonadotropins are low. And that's when a random FSH and LH is very helpful, okay? Because if you have high FSH and LH, your gonads are failing, but your pituitary is working just fine. And your hypogonadic, you know, your gonads are fine, but your pituitary is failing. So since the differential is so different, get an FSH and LH first. And you got to figure out then if you're going to be going down, which pathway you're going to be going down. So another syndrome, XXY, 1 in 1,000 males, small testes, seminiferous tubule dysgenesis, behavior problems, below average IQ, gynecomastia, and unicoid proportions. And that is Klinefelter's, very good. And that's an important one. Got to know this one. 1 in 500 to 1 in 1,000, 46XXY, seminiferous tubule dysgenesis, the most common male sex chromosome abnormality. So it's going to present at different times. If they're having significant behavioral problems, you sell them to a developmentalist or a geneticist, and what do? They get chromosomes, and they stumble upon it, basically. But they, fire setting. I don't know, these kids like to set things on fire. So if you see that buzzword, you know, think about Klinefelter's, okay? And then you miss that opportunity. Then they come in, and when I was I did general peds a lot. When I was in the military, I did all those darn physicals, which I'm sure you guys are doing right now. And then these kids would come in, and I got a few of them there because, I mean, 1 in 500. You got to think, I've seen 500 males, right? How many Klinefelters have I diagnosed? But you see, they do the general exam. Nobody likes to do it. You just got to do it. So what do? You know, potentially they just look at the hair because there's nothing wrong with their adrenal glands, so they're going to have lots of hair. But if you don't feel the testes, you're going to miss it because the testes are small. They usually get about, you know, they start puberty, and they usually stall out around about 8 cc's, so relatively small testes, okay? Gynecomastia, and they get 7 out of 10, almost as high as ladies, that get breast cancer. So they have to learn how to do breast exams. And then you have to start testosterone therapy. That's debated, but usually around 11 or 12. Another syndrome, another good one, a lot of board questions. Male or female, web neck, mental retardation 25% of the time. These folks get the pulmonary valve stenosis. They're short, pectus, increased risk for ALL and CML, and hepatosplenomegaly. And again, that is Noonan's, right? So it's the male turners, but females can get it too, right? But 1 in 2,000 live births, chromosome 12q, a lot of good board questions, similarities versus different than Turners. Similarities are short and have the web neck, they have the pectus, and the cubitus valgus, you know, they can't quite straighten out their arm. Differences, MR 25% of the time in Noonan's, but in Turners it's problem solving. They have a lot of learning disabilities in math, maybe sciences, things that require a lot of thought and problem solving. Noonan's cardiac is the pulmonic side, and in Turner's it's the aortic side. So those are the differences which are important to know. So know the similarities and differences between them. Buzzword for this one, retinitis pigmentosa. I mean, that looks like Mars, but that's actually retinitis pigmentosa. I've never seen it. Obesity, polydactyly, MR, and hypogonad. So obesity and the MR and hypogonad kind of sounds like Prader-Willi, but this is Lawrence-Moon-Bedell, or also known as Bardet-Biedl syndrome. So again, if you see that retinitis pigmentosa and the polydactyly, that's what you want to hone in on, and that's the syndrome you need to answer. Another one, interesting, hypogonadotropic hypogonadism. So something wrong, the central part, right? They can't have a sense of smell or a very poor sense of smell. And this is due to this migration gene defect at the CAL gene, okay? So this is Coleman Syndrome. And it was always, you know, that migration gene thing just came out a few years ago. So when I was a fellow, I'm like, gosh, what the heck does your olfactory bulb and your hypothalamus have to do with each other? But they start next to each other in, you know, during embryology. And this CAL gene, this migration gene, that gets the hypothalamus where it needs to go and gets the olfactory bulb where it needs to go. And it's the absence of that migration gene that causes this syndrome. So you can measure that. So anyway, that's a good board question right there. Another good board questions, lots of questions on this one. They're hypotonic at birth. They don't move a muscle. I mean, you know, and as a result of that, they don't feed well. So they're often failure to thrive at birth in the first year or so. And then they start getting heavy, and they eat a lot, and they can't stop eating, okay? Their MR, they have mental retardation, low IQ, they're hypogonadal, and again, great board question right there, deletion of the Q11-13 region of chromosome 15. And you all know that is Prader-Willi. But again, hypotonic at birth, failure to thrive at birth, they can't eat real well. And then they start eating a lot. They tend to be blonde hair, blue eyes, fair skins. This crazy question, small hands and feet. I saw that on a board question. That's the only bone they threw was small hands and feet. I'm like, holy moly. But that's what they want you to think of Prader-Willi. Okay, it's all this buzzword connecting sort of thing, okay? So small hands and feet, Prader-Willi. The other thing is this deletion at the chromosome 15. If it's the paternal deletion, you're going to get Prader-Willi. Maternal, it's the Angelman syndrome. Okay, so good board questions right there. Another syndrome, absence of the septum pellucidum, optic disease, and pituitary disease. This is a common one that we see, and it's septo-optic dysplasia. So the septo part is the absence of the septum pellucidum. And to be honest with you, that's usually, I mean, I never make this diagnosis. They come to me with the diagnosis, and they ask me to evaluate the pituitary part. Because usually what happens, the kids get some imaging of their head for some other reason, and it's blah, 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 blah. And, oh, by the way, there's an absence of the septum pellucidum. I'm like, oh, and so that starts the ball rolling. And then you look at their eyes, and they can have just pale optic discs to total blindness. So there's a huge spectrum there. And then they come to see us in endocrine, and they can have nothing to panhypopit. So it's not, I mean, the only thing that's really 100% is that absence of the septum pellucidum. And again, a lot more genes. I had to recertify this year in endocrine. I'm like, oh my gosh, all the genes and the gene markers that are now out there. So I'm throwing some of them at you they may start showing up on the PEDS boards too. But this, they found a genetic defect in the HEX1 gene that causes this. So again, I had another big pile of note cards that had, genetic defects and what it caused. So that again is something that we're going to right now. So HEX1 is the genetic defect there. Another one, you're going to get some board questions on this one, okay? This is interesting. 3% of conceptions, but 99% of them spontaneously abort. 45XO, they're 100% short stature. The only thing that's 100% in this syndrome is short stature, and it's the absence of the SHOX gene. They have short fourth metacarpals. They can present classically with swollen hands and feet at birth, learning problems in math, the aortic disease, they're hypogonadal, and they have kidney disease also. And that's Turner's, right? So again, XO is the most common. There could be mosaics. If there's a Y chromosome attached, you got to know that because that puts that kid at risk for cancer. So that's the only time you got to get those streak gonads out of there. Otherwise, you can just leave them be. But if there's a Y chromosome, you got to get them out. Again, I talked about 3% of conceptions, but 99% abort. Okay. Maternal X seems to be the problem, but does not change with increasing maternal age. And this was a board question one time. You want to get a karyotype. I mean, buccal smears, oh my gosh. I'm sure there's some little clinic out in the middle of Ohio someplace that still does it, but you shouldn't be doing buccal smears. You get a karyotype. Again, the only thing that's 100% is short stature. I'll have kids come into the clinic and I'll say, look at the resident. What's wrong with that kid? Oh, they look fine. Well, they have Turner's. Well, they don't look like they have Turner's. Well, a lot of kids don't, It's just a short stature. So that's why it's standard of care when you're working up a girl with short stature, you've got to get a karyotype, okay? Again, the web neck, the cubitus, short fourth metacarpal, the low posterior hairline. Again, problems in math and problem solving, but otherwise normal IQ. And they're going to present 3 different times. They come in the nursery and they have swollen hands, swollen feet, the Turner's. Second time they're going to present is if they start decreasing their growth velocity. Because you're as tall as you are with the Turner's based on how tall mom and dad are. So you may be in the, the lower end, but you're hanging in there. And then around 3 to 5, they start decreasing their height. And then if they made about those two, there are some that make it all the way to puberty. And I got a lot of board questions on this where 15-year-old girl comes in and, maybe tan or 2 breasts, but tan or 5 pubic hair, but no menses. Again, with Turner's, there's nothing wrong with your adrenal gland. You'll make all the androgens you want, so all that will happen. There's a problem with your ovary. Cardiac, again, it is the aortic side, and the new recommendation, they got to get echoes every 5 to 10 years because of the risk of aortic dissection. So they get an echo at birth, and if everything's fine, they still have to get it every 5 to 10 years because of that risk factor. The kidneys, again, at birth, you got to do a renal ultrasound, and if everything's fine, you're good. So, but about 20% have collection system abnormalities and 10% with horseshoe kidney. When do you begin? Growth hormone with decreased growth velocity, okay? I'm sorry. And estrogen, we used to start at like 15, age 15. The recommendations are started at a more appropriate time. That other girls are going into puberty, which would be about 12. And they do these patches instead of oral. 2 things. It doesn't make estrone, which is not as physiologic, and the oral estrogen was associated with growth hormone resistance. So no longer you do the pills, but you do these patches. And then you just sort of start mimicking puberty, and you do the patch, and once they start having breakthrough bleeding, you start the progesterone. But again, the new thing is that you're starting the estrogen earlier, not at 15, but more like at 12, so they're more normal, like the other girls. Constitutional delay, this is a good board question. You got to understand this. These are kids that they start off and they're normal, and they fall off the growth curve between 18 and 24 months. And then they grow right along the 3rd to 5th percentile. At puberty, they have a little bit of a dip, and then they go through puberty a little bit later, and then they're fine. Again, their bone age is delayed, and their dental age, they tend to lose teeth a little bit later too, okay? But normal growth velocity and a delayed bone age, and that's the definition, and you can just leave them be, okay? But sometimes, I mean, they're waiting for puberty and waiting for puberty and waiting for puberty to start. If their bone age is still 2 years delayed, they're going to be 2 years delayed in their puberty. So, interesting. Girls get this. We never see girls. Nobody wants the little girls that go into puberty. We see the boys because the boys have to go through puberty, right? And so we'll give the testosterone to the boys. I've never seen a girl with I mean, they're out there. They just kind of keep them at home. It's okay if they don't go through puberty, right? So for those boys, they need to play football or whatever they're playing, right? So, but you can. Now, you say, okay, well, you can just give them testosterone to sort of jumpstart puberty. You're going to go from like Tanner 1 to Tanner 2. Because otherwise, they're going to take 2 years to get to that point. And they're not going to be growing. Everyone else is be growing. And these kids now, to be honest with you, just kidding, they get bullied. These are the kids that get bullied. You know, they're little, and the bullies pick on them. So, you know, I tell them, I can make you big and hairy and muscular and give you a bunch of testosterone, you know. But that's not going to do them any favors, because if I give them too much testosterone, you're going to fuse their bones, and you're going to lose all their growth potential. So all I can really do is just jumpstart it with like low-dose testosterone, about 50 milligrams once a month for about 6 months. Adults, 300 milligrams once a month. So it's a really very low dose, just enough to jumpstart and get things going. Okay, on to growth. Puberty and thyroid are the two long ones. So 15-year-old, parents concerned about his size. He's currently in the 5th percentile for weight and height and has been growing at that percentile for years. His midparental height is 72 inches, good appetite, very active after school. He's normal except for in his Tanner 2 pubic hair, 5 cc testes, and his bone age is 13. So, reassurance, a testicular ultrasound, a dietary consult, FSH and LH, or a testosterone level. You know, put your answers in. Very good. It's reassurance. Because, again, this kid has started puberty. You know, he has 5 cc testes. He's in puberty. He's been growing at that. He's following a normal growth velocity. So you just let them go. Now, if he was 3 cc testes, then he'd be seeing me, you know, because he'd be delayed puberty. But he has constitutional delay. You don't want to mess that up. You just let them go at their own pace. So normal growth, fetal in utero, it's a good board question. The growth factor is insulin. You think about the insulin, the babies of a diabetic mom, and they're really big because potentially a lot of insulin on board. Growth hormone has nothing to do with growth in utero or in the first few years of life. Babies with growth hormone deficiency don't come out like teeny tiny. Growth hormone in utero and in the newborn period is a counter-regulatory hormone. It controls your glucose. So congenital growth hormone deficiency will present with hypoglycemia, right, in the newborn period. Then everyone, you know, you have these, see these kids, and they're up and down in their growth curve. Which one are they going to pick? They pick it by 3. So they pick their growth percentile by age 3. Going up or down after age 3 is a red flag, okay? So, and it's abnormal. Now, growth hormone is released, again, in these pulses, and it's positive with the GnRH and the negative with the somatostatin. Now, sleep, you know, you say, go to sleep, you're going to grow. You know, Grandma used to say that. It's true. You do a lot of your growing during your sleep. You have these growth hormone pulses, especially in stage 3 to 4. With REM, there's actually a low growth hormone secretion, but 3 to 4, you do have maximum growth hormone release. Right prior to puberty, which you can see sort of in a growth curve, they slow down a little bit and then they take off. So the average prepubertal is about 5 to 6 centimeters a year. With puberty, it could be 8 to 10. Again, as we talked about in girls, it's stage 3. And by the time they have their menses, they've done 90% of their growing. And for boys, it's stage 4. So good board questions. So when I'm looking at a growth curve, and if you're looking at a growth curve, you've got to look at it relative to the height and the weight and the OFC. Okay, the head circumference, if they're, you know, still using those. So if everything's down, the height and the weight and the head circumference, it's usually a preemie or probably a syndrome. Okay, so sort of general sort of things. If the head circumference is normal, but their weight is greater than height, you know, short and fat, that's us. We'll take all the short, fat kids because they are at risk for a hormone problem, okay? And that would be growth hormone deficiency, hypothyroidism, or Cushing's. Those are the big 3. Okay. Now, short and skinny, probably malnutrition, probably GI, maybe renal disease, maybe nutrition, they're just not getting enough nutrition. We see those kids too. We'll see them, but we then send them on to GI. But again, short and fat because those hormones are required for normal growth and normal weight. So growth hormone deficiency, when you're trying to make that diagnosis, idiopathic is the most common. But other things that can make you growth hormone deficient, you can have growth hormone insensitivity, where you have high levels of growth hormone, but low IGF-1. You remember growth hormone goes to the liver. The liver makes IGF-1. So sometimes there's not a good communication there. You can actually treat with IGF-1 now. Anything midline, Septo-Optic Dysplasia, cleft lip, cleft palate, the single central incisor. I mean, I've seen that. I saw in my research, again, this kid with this big tooth in the middle of their head, That's growth hormone deficiency, okay? And I've seen it on PEDS boards, endocrine boards, and all my research. I've seen that question. And I finally saw my first patient with it like a few years ago. And I almost fell off my chair. I was so excited. But, yeah. So, and then I was like, this kid has a single central incisor. And so initially, the residents would be able to see it, but then she knew, her tooth, then she got more self-conscious. So she used to, take her lips and sort of purse them around her teeth. And so when she would open up her mouth, you couldn't see her teeth. So it's like we lost the opportunity because she became a little bit more self-conscious as she got older. But yeah, but that's a great board question, growth hormone deficiency. Now, cranial, that's the thing we worry about. You have a tumor, okay? Lateral skull is a good screen because 70% of them are calcified. So people that are, away from medical centers get a lateral skull. I mean, I don't get that. We'll go right for the MRI. A tumor, hypothalamic, ectopic posterior pituitary, and that's what this is right here. This here, I'm not very good at this, right there, the bony part right there is the sella, and that's where your anterior pituitary sits. It comes from Rathke's pouch. And this bright spot right there, you see that right there? That's the posterior pituitary. And it comes from the third ventricle. And it's supposed to migrate down and sit right on top of the anterior pituitary. When it does that, it makes the infundibulum. And then with the infundibulum, you can make the portal vessels. So now you have communication between the anterior pituitary and the hypothalamus. So in ectopic posterior pituitary, really the problem is with the infundibulum or the pituitary stalk. And if you don't have the stalk, you're going to be panhypopit, okay? So, but it's an embryological problem. There's nothing wrong with the anterior pituitary. The problem was with the posterior pituitary and the migration. So there's no communication. So the pituitary stalk is key in determining if you're going to be panhypopit or just growth hormone deficient. Ectopic posterior pituitary with a normal stalk, you're just growth hormone deficient. But if you have an ectopic posterior pituitary and abnormal stalk, you're going to be panhypopit. Okay, this is when I get the tomatoes thrown at me. I mean, this syndrome is, you're going to see it. I seen it in my fellowship, and there's a group in Dayton, and that's it. But it's a great board question because it has a lot to do with physiology. So, parathyroid hormone resistance, low calcium, high phosphorus, because that's parathyroid, hypoparathyroid, but a high PTH. So you have to have that lab. Plus, you have to have this phenotype, like short and squatty, okay? Just think about short and squatty and round, okay? They're short, they have short fingers, short toes, they have a round face, and the whole family comes in and everyone has it, and they're all sort of short and squatty. So that is pseudo-hypoparathyroidism, and they love asking this question, okay? So, if you're hypoparathyroid, again, you have the low calcium and the high phosphorus. The pseudo part comes in is because the parathyroid is really very high because you're resistant. So that's why it's called that. So now the other problem is that there's a whole bunch of them. There's 1A, 1B, 1C, there's pseudo-pseudo, and pseudo-hypopara 2. Blah. Okay, so what do you need to know? You need to know, again, this is another genetic marker, this GNAS, okay? If there's something wrong there. So the two that you need to know are the pseudo-hypopara type 1A, and that's the mom causing it, and the pseudo-pseudos, which is the dad causing it. Okay, so we'll talk about it a little bit more in the next few slides. But again, GNAS, if it's the mom, it's the pseudo-hypopara, and the pseudo-pseudo for the dad. So what is all this? Okay, so again, the pseudo-hypoparathyroidism type 1A is the one that we just talked about. Low calcium, high phosphorus. Oh, they're hypopara. No, they're pseudo-hypopara because their parathyroid is really high. Okay? And again, they're short and squatty, round face, short fingers, short toes. Okay? And it's the mom that's causing this. Okay? So you see that kid, you make that diagnosis, and then the next kid comes in, and lo and behold, they're round and they're short and they're squatty and they have short fingers and short toes. And you're like, I know what this person has. They have pseudohypopara. And then you do labs on them and they're normal. And you're like, oh, I don't get it. But they're the pseudos. Okay? So the thing that's common is this phenotype. Okay? The short, squatty people. The thing that makes them different is that abnormal labs versus normal labs. Okay? So is that a Venn diagram or whatever? I think, the common thing is a phenotype. The abnormal things, which makes them unique, are the labs. But again, this GNAS, it's the dad causing this one, okay? It's paternal. There are more P's, okay? Pseudo, okay? And the maternal one is just a pseudo. So just memorize that like 10 minutes before you take the boards and then throw it away. Okay. You'll never see it. Russell Silver, it's a short kid. The big buzzword is this incurved fifth metacarpal and the triangular facies. They tend to be short, small for gestational age. And we talked about this congenital growth hormone deficiency. They come out normal because, again, it's insulin that makes you grow. But three things that you'll see. If it's a boy, they're going to have a microphallus because IGF-1 is what you need for penile growth. Second thing, they can have a direct hyperbilirubinemia to the point where they almost look like they have biliary atresia. They have sludging because, again, you need growth hormone to move the bile through the liver. And then the third thing is that they get hypoglycemic because you don't have the counter-regulatory hormones. So those are the things that you'll see with congenital growth hormone deficiency. Single central incisor, again, know this for the boards. Just that big tooth. I've seen like little nooks and stuff that they have with like the big tooth. I think I've seen them in Kentucky when I was down there. But yeah, it's the single big tooth in the middle of the head. Think about growth hormone deficiency. Okay, so the kids, you do a lot of evaluations for growth. Again, we got to look at the height, the weight, and the OFC. Not everyone reads the book, but ideally they're not gaining height, but they're gaining too much weight. And that's the classic endocrine kid. So you're evaluating them. One of the things you're trying to figure out, are they a candidate for growth hormone? There's 10 criteria for growth hormone that the FDA said. So one of the things, if they're SGA and they don't catch up by age 2, that's, they're a candidate. And I find it a little bit more challenging in the civilian sector because in the military, you always have the military records. You can figure out how big they were at birth. But it's hard to sometimes track down their birth weight and height and length. In the civilian sector, if they've moved around and they haven't stuck with the same hospital. So anyway, but you got to figure out what their birth weight and height is, and if they were SGA and they have not caught up, they're a candidate for growth hormone. This is the workup that you should do before you send them to see an endocrinologist. You want to get the CBC and DIF, looking for chronic anemia like inflammatory bowel disease. I've made that diagnosis multiple times. SED rate, looking for inflammatory bowel disease. A Chem-10, again, ALK-Phos. Liver, kidney test, thyroids, a urine, looking for DI, which will, they don't grow well. The 2 growth factors, the IGF-1 and the binding protein 3, and then the celiac. And then always get the bone age. Again, girls, the only thing 100% with girls and turners is short stature, so you got to get the chromosomes. And the kids that we do the growth hormone stim tests on are the ones with a normal screen but a decreased growth velocity. There are side effects of growth hormone therapy, the SCFE, the pseudotumor, transient carbohydrate